Good morning, everyone. We have to do a little bit better than that. Something that Kathy probably didn't mention to you that if I weren't a scientist or an administrator, I would be a Baptist preacher and a comedian, particularly a stand-up comedian. And one of the things that you probably are familiar with, that when you go to Baptist churches in the South, and particularly if you are a comedian, a particular stand-up comedian, that you need energy. And you drug me all the way from warm Miami to blizzardry. So we got to do better than that. Good morning, Michigan. Good morning. All right, now we're talking. All right. Well, first of all, thank you very, very much, Dr. Goldstein and Victoria and Srinjan and the entire MeTRIC team. Particularly thanks to the University of Michigan family for giving me a very warm welcome, despite what outside looks like. But I'm extremely honored. I'm extremely honored to be here. Particularly because when I'm looking out at you all, you are the epitome of commitment, because anyone who braves these elements early in the morning to listen to a weird, funny name guy from Jamaica, from Miami, shows a high degree of commitment. So my job is that it will be worth your while. But outside of those, commentaries, I want to sharpen the focus of today's conversation. I think that as I was reflecting, I actually traveled here during the snowstorm. And, I had reached out to Kathy and others, and I'm like, are we sure we're having this? Not that I was trying to get out of it. But as I reflected, I realized that especially what we see going on globally and geopolitically, that every moment must have purpose. Because if we don't seize the moments, then these moments then become monuments. But if we seize it, these moments become movements. So it's not coincidental that a week after celebrating the life of Martin Luther King Jr., that you will host a fantastic and incredible symposium on how is it that we can serve. Not saying that I'm hearkening my Dr. Martin Luther King, because that would be blasphemous, even though I referenced being a Baptist preacher, hopefully. But I think it's important that what I will share with you today is not necessarily showing you all the bells and whistles, and I can talk about that. But I think it's even more important, given where we are as a society, that we must capture what's the meaning of our work. It's one thing to choose devices and the like, but what is the meaning of our work? And I'm not trying to be political at all, but as scientists, everything that we do, every action we make, every decision we make is a statement. And my hope is that I'll convince you that you must do so with meaning and purpose. Now, in full disclosure, the name Metric-ULATE actually was me paying homage to the MeTRIC team, that because it is called MeTRIC, we have a program that we have never named, to be quite honest. And so it is my gift to you all that Metric-ULATE, if you deem it to be worthy, that you can adopt that framework. So Metric-ULATE is Michigan. This is my gift to Michigan. But the reason why this is important is because I want to focus on leadership and linkages, and how is it that we can adopt our technology across multiple ecosystems. And I don't have to convince folks, but one of the things that if you are in the business of innovation, that I believe that we typically innovate around challenges. And I think I don't have to convince you all because I am preaching to the choir here, that there are increasingly vexing health disparities, that we are seeing that chronic disease management is at a critical and crisis stage. That as we are aging, that we are not necessarily aging in place and we're not allowing people to lead and live quality lives. We also recognize that there's a significant mental health crisis and that people who provide care are asked to do more with little. And we also recognize that there is a fragmented healthcare system, that we are actually not meeting people where they are. But we don't just innovate around challenges, we also innovate around opportunities. And we have to be able to seize new frontiers in order to make healthcare more whole. We can do so through improved decision-making, through precision medicine, or improved patient engagement, or to find better ways of managing populations. But I'm going to lay something out to you today, that we don't just innovate around challenges, and we don't just innovate around opportunities. But what we are called to do today is that we must innovate around an ethic. That the work that we do is not just for a grant, but it's a calling. The work that we do is not just for scientific impact, but it's our duty. And the work that we do must be responsible, because whatever we put out there has to bear consequences of our decisions. Because the ethic that we currently use is that we try to optimize efficiency and minimize risk. Equity is treated as optional, and we see this in the obliteration of diversity, equity, and inclusion. That ethics reduced to compliance, and virtues without duty disappear under pressure. That's the old way, that's the old ethic. My proposal to you is that we need a renewed ethic, an ethic in our work that advances human flourishing through knowledge, where we can ensure innovation, that we can serve people, not just systems, and we can serve all, that we design for real users and not ideal conditions. And our greatest and most sacrosanct virtues are trust, truth, and future generations. Ethics is not an add-on. DEI was never an add-on, and I'm not trying to say I'm an advocate or an evangelist, so I don't want you all to chase me out of University of Michigan. I'm not trying to propose that. But the one thing that I want to highlight is that it should be a North Star, because it keeps innovation human, it keeps innovation legitimate, and it keeps innovation durable. Because it's through ethic that governs our professional actions when efficiency and incentives and acclaim or applause go in the wrong direction. This is what is at stake. And so the ethic that we use in our work is that innovation should be with and for a purpose. We call this the real IP. Typically, when people talk about IP, they talk about intellectual property, and I don't think I have enough time to talk about philosophically and spiritually why intellectual property may not actually get us to make healthcare more whole. Because the old model of intellectual property is that we get enamored with what tools are faster or what devices are better and efficient workflows. But one of the things that I want to say is that IP, intellectual property, only helps us to solve the complicated. But we know that in healthcare and in research that we're not just trying to solve the complicated. We are trying to solve the complex. Issues around health inequities, issues around chronic disease, and issues around trust and adoption. That's what we have at stake, folks. Yes, we can bring the best technologies to solve the complicated, and those are important. But I believe as scientists, we need to reclaim our rightful place. I always say this, and I love my tech bros and tech gals, but when did they become the philosophers of our world and our community? That everyone is just seasoned to hear what Elon or Jeff Bezos has to say. We are the ones who have to pursue that. That's our rightful place. This is who we are. And so this new ethic is one that we have to be innovators with and for a purpose. Because when you say that I am trying to create an intellectual property, it actually forces you to just think about ownership of whatever you produce. But when you create a solution that is innovative and it is filled with purpose, then you are focused on purpose. Then you're focused on duty. Then you're focused on responsibility. And then you are focused on stewardship. Because IP is not just a tool. It's not a goal, folks. It's an ethic that turns innovation from ownership to obligation. That is the paradigm shift that we need. So whenever you're putting together your fantastically sophisticated projects, do know that you are actually not just solving for a challenge or seizing an opportunity, but you have an ethic as well. You have an obligation for what you study, who you study, and the results that you actually produce. Now, you may ask, say, well, Azizi, that's a good part of the sermon. I feel as if that I'm convicted and I'm going to give more tithe today because I feel convicted. That's not what the purpose is. But I think it's important that we reframe our thinking. But then the question is, how is it that we can operationalize this new ethic? How do we turn innovation with and for a purpose to something that is operational? And my hope is that I will kind of reflect and share how we have built it at the University of Miami and prior to that when I was at NYU School of Medicine. And so what we focus on is purpose without execution, right? Where it becomes just mere aspiration. Execution without purpose is just mere efficiency without legitimacy. And so the goal is to stitch them together, to integrate them. That is the critical thing, where we're focused on purpose and execution at the same time. And so how is it that we can lay this out? It's through this Metric-ULATE program and framework, where it is an operational model that makes innovation more adoption, like focused on what's measurable, what's executable, and what is durable. And there are two components of that. So whenever you're rolling out any type of digital innovation solution, this is what we always do when we kind of put new projects together, that we focus on what are we going to measure. Yes, you can focus on the outcomes and the like and the endpoints, but we focus on who are we reaching and how are we going to reach them? How are we going to engage them? What does equity look like in this situation? And we actually have, even predating what we're seeing in our, kind of new current discourse, that I personally stopped using the word equity because I realized that it was hijacked in a way that people were trying to misuse what we're actually intending and what we're meaning. So we always say health for all. No one can say anything about that. Health for all. It's for all. The solution is for all. What does that mean? Health for all. Simple as that. Okay? And so we want to focus on that type of equity, adoption, and sustainability. But then also, we want to focus on uniting the leadership because that's critical, particularly in my role as chair of the Department of Informatics and leading other different groups at the University of Miami. It's important that we are aligned in terms of the leadership, ensuring that we connect the dots with the linkages, And when you create the technical architecture as well, particularly, you want to make sure that it can serve all. And then we focus on training, because training can help to tailor, and then evaluation is important. And the goal is, or simple equation is, that when you have leadership married with linkages and measurement, that it leads to scalable, sustainable, inclusive programs. Because our goal is that we ask ourselves, does it work for the people who are typically least served? Our philosophy is this, that the best solutions need to be given to the least of people. And we believe that if you actually innovate for the common denominator, for the average person, then it can be scaled to everyone. It's very counter to how most innovation hubs, like in Silicon Valley, they create all these fantastic, great tools, but they oftentimes focus on the people who can afford these solutions that are very expensive. And they worry, why is it that it cannot be adopted? Why is it can't be scaled? Because they did not innovate for the common person. And that is important in any work that you do. So then how you move it from challenge to opportunity to ethic to scale. And I'll walk you through the spine of how we actually do this. First, there is a governance structure, then there is linkages, then we lay out what we call these metric outcomes, and then I'll share with you how we've gone about implementing this across 5 vertical areas, and then I'll lay out for you how we've been able to scale that. And the reason why that is important is that purpose really guides us, right? That's the leadership. It guides what we actually create and what kinds of programs we establish. The systems and the linkages that we create, they actually help us. And that's kind of, I'll walk you through the vertical structure. And then the metrics allow you to kind of enforce, because the measurement makes values concrete and accountable. And then we'll focus on how is it that we've gone about to scale this. So let's focus on governance. Now, governance sets purpose and ethic, right? And that's the leadership. And one of the things that we focus on is that we have to define why we innovate in the first place, right? And we oftentimes lay out these very elaborate but simple strategic intent and what is the moral foundation of this program? Why is it that you're using a Fitbit? Why is it that you're studying physical activity? Why is it you're studying sleep? And so a lot of the work that we do really focuses on urban and rural communities, particularly on hard to reach communities. They're not hard to reach. I always tell my staff, like, show me the hand of someone who wakes up every morning and says, golly, I would really, really like to be part of a study today. No one does that. No one does that. And if someone calls you and says, hey, I want you to be part of a study, you have to give me blood work, and I'm going to monitor and track you for the next 6 months, and I'm going to learn everything about you, I'm going to be very intrusive and all of that, what will your answer be? No. No amount of money. So we have to then make the case why. Why do we innovate? And we've done some work on, through the partnership of Merck, where we have studied that people are driven to participate in studies because of altruism. And maybe if we have enough time for questions and answers, I can talk a little bit more detail about that. But it's also important to establish what the duty and responsibility is. So what are some accountable ownership structures? So for us, every program that we create has a community steering committee, not an advisory board, because advisory boards typically means this is our idea, what do you think? Is it good or bad? Okay, co-sign it. But a steering committee co-creates projects and sets the agenda, and they are equal partners in the leadership structure. And then you also want to ensure from a governance structure that you want to set what the non-negotiables are. And for us, it's oftentimes, especially since we do a lot of digital health work, is we want to make sure that we prevent harm, that we want to ensure that we serve all, and that we build trust. So governance is not just about bureaucracy. It's really the moral grounding and the strategic leadership of any program that we establish. Because when you have a program devoid of this form of governance and leadership, that what ends up happening is that default mode kicks in, where efficiency replaces purpose, risk minimization replaces responsibility. I'm sure many of you would have brilliant ideas and you go to IT or you go to your leaders and you're like, nah, just no, they like incremental change. And there's an avenue for incremental change, but we are trying to tackle and solve some vexing healthcare and scientific questions. And we really must be a little bit more daring and a little bit more ambitious. And this is where governance and leadership is so paramount, to be aligned. And you need to find great champions to do this. So this is why I love what MeTRIC is doing, because they serve as a quasi-governance structure to help you deal with some of those government alignments and leadership alignments, because that is so critical. And if your governance is absent and if you don't have great, bold leadership, then issues like equity becomes optional. And I kind of hearkened to that previously. This is why you have seen many different, institutions have rolled back on DEI. I know, and I understand some of it has been cosmetic, because I think, what people have unfortunately endured and suffered with this new framework and discourse around being kind of inclusive and ensuring that everything that we create is for all, that yes, you have to respond to that because there are some real life business issues. But guess what? When you have purpose on your side, you do not need permission. If you are doing good work, purpose should always drive this. And you will find ways in order to effectuate this. So you may ask, if we're trying to build a governance structure, then who should be a part of this governance alliance? And we oftentimes focus on key stakeholders. These could include patients or caregivers or communities. I mentioned the Community Steering Committee. This could include clinicians or people in the operations or on the front line. This could also include decision makers, IT, security, compliance. That could include legal and the like. It would also include you all as researchers, maybe informaticians and engineers, and then industry partners as well as payers and policy makers. And you may say, well, Azizi, I'm just trying to do a quick pilot study. Like, why do I need to bring payers in? And that's the issue. My encouragement to you all is any study that you are focused on, you need to focus on what level of impact it will have. It doesn't necessarily mean that it needs to be scaled into a policy today, but the arc of your research program should bear that in mind, because at the end of the day, the goal is not just to write a paper. It's just not. Those are important deliverables and KPIs. But one of the things that I want to share with you is because there are so many people. I go into communities all the time, not just in New York City, not just in South Florida, but globally. And I'm telling you all, and I'm not trying to give you guilt or anything, but you all are very blessed. And I've always lived by this virtue that to whom much is given, much is expected, and to whom more is given, much more is required. The world is waiting on you. The world needs you all. Because the rest of the world doesn't look like you all, and I don't mean this visually. They do not go to an enormously fantastic school at the University of Michigan. They're living paycheck to paycheck. Some people don't even get paychecks. So the arc of your work has to be impact. The arc of your work needs to be personified. I always think about my single mom working 2 jobs, and I watched her work 2 jobs and get a PhD. You have to bear that in mind, because so many people are waiting on you. Now, outside of governance, then linkages are important. Why? Because the linkages helps us to tackle and solve these complex problems. Why? Because when you focus on solving the complicated, you're only focused on solving linear types of relationships, right? Linear workflows and principles and the like. And one of the things that I want to share is that in order for you to have a robust program and robust digital or innovation program, you must actually focus on the linkages in between ecosystems, linkages in terms of stakeholders, linkages in terms of other key constituents. This is important. And this may look like cross-sector collaborations, and that can allow you to establish more shared value propositions, because at the end of the day, you want your innovative solution and programs to be durable. So you need to be able to establish shared value proposition, shared definitions, shared workflows, and shared data governance, and shared sustainment plans. That is important. And I love what MeTRIC is doing, and I would strongly encourage MeTRIC to really double down on offering these as additional resources as well, because you can have multiple pilot programs and some may work because that's how all research and all exploratory work is. But at the end of the day, there needs to be purpose, or what Aristotle talks about in there needs to be this telos, where he says it in the Nicomachean Ethics. You must have that telos for every program. And in order for you to establish and ensure that each program has that, you must have this cross-sector collaboration where most of these things are shared. Now, the question is, how is it that you can actually create this program? And I'll lay out to you what we framed as a metric outcomes. And thanks to Kathy, because I have always looked up to Kathy. And when she invited me, and she was telling me what you all may want to talk about on here, and I'm like, you know what? I want to laud and anoint Kathy on her work, because she's doing some really great work here. And here's what metric does in my reflection, and this is kind of what we do too at the University of Miami. When you're trying to put together an evaluation as to whether or not if you're doing impactful work that focuses on solving challenges, seizing opportunities, and having an ethic that grounds your work, that you must have metric. What's the meaningful impact of your work? Does it have clinical, behavioral, operational salience? What's the equity? Does it serve all? What's the distribution of benefit and burden of that particular solution? So even though you give someone a device, the question is, does it even work? I remember when we, we do sleep research as well, and we did this in the Bronx, and we would have these old, black ladies would see what the actigraph looks like. I don't know if you've seen them at all, but they look like you're being tracked. You're in the system, and they're like, "Where am I putting this? On my wrists or on my ankles or what?" And they're like, and I'm like, "Whoa, I didn't even think of that." And she's like, "No, honey, I'm not doing that," right? And so it is important that you want to have them be a part of it as well. And equity is an important thing. And though you may provide a digital solution, that it could be a burden as well. We created a remote health monitoring solution, which I'll share with you soon. And we would say, don't worry, you don't have to come for it. We'll FedEx it to you. And they're like, honey, I live in a tenement yard. I have a P.O. box. And I'm like, we can't send it to a P.O. box because we have multiple devices. Our box altogether costs about $1,200. That becomes a burden. So not because you're delivering a digital solution, you think of it as just a benefit, but you also need to look at it potentially as a burden as well to them. It's also important that you focus on trust and acceptability, reach and recruitment, efficiency as well. So it's not just to reach people, but to recruit them, but also to, and I hate to say this word, but how to keep them in. Typically we say retain, but it sounds a little bit too draconian. But it's important that you lay out plans for that, because it's important in any kind of digital or innovation solution. Then the implementation and adoption. What is the uptake of it? And It's not just about giving someone a device or a solution, but even in clinical workflows as well. How will the system react to this new implementation? That's important for you to look and see how that will impact as well, because I believe that many of the failures in AI solutions, and it's been well documented, it has nothing to do with the ingenuity of the technology. It has everything to do with how it was implemented and how it was adopted. That's real. Because you can give people the best of technologies, all the bells and whistles, but if it just doesn't solve their immediate needs, and if it adds, as I said earlier, significant burden in their workflow or clinical streams, they're just not gonna buy into it. And then lastly, you also need to focus on the cost of sustaining this program. And I oftentimes have this 4-year arc. Can we sustain this program after funding 4 years after, right? And that's a legitimate question. So any of the programs that we create, we want to align with our senior leadership to say, if we don't have funding or we partner with other researchers, if we don't have any funding, how can we sustain this program? And it's important that you do that. So if you have a checklist per se, this is the Metric-ULATE checklist, it's important for you to build an ecosystem map before you develop or implement any form of new innovation. Why is this important? Because when you actually put together that ecosystem map of who the key stakeholders are, who will help you in the operationalization of your solution and actually deploying it, if there's a no, you gotta fix it. You have to fix it. Because what will end up happening is that it may work for some, but if this particular group of individuals are an important cog in rolling out your program, then it's not gonna work. Then obviously you wanna make sure that you focus on the metric components that I just highlighted. You wanna focus on real kind of support model where, if you're rolling out a new solution, and I think Metric is doing this as well, if you're rolling out a new program, and we've done this, we created a remote health monitoring solution, and we've distributed it across 1,500 Black and Hispanic individuals. And people would always tell us, that's never gonna work. And if I were to tell you, we have an 88% compliance rate in terms of people using 2 smartwatches, a smart ring, an ambulatory blood pressure monitor, as well as an air quality device and a smart scale. And it's not because what we created was just ingenious. We just have a human in the loop. We have that help desk where we onboard folks. And we've done this, and we're talking to individuals, and I'm not saying that these people are lesser per se, but we're talking to people who are monolingually Spanish speakers, right? And in rural, Florida. And so this has worked extremely well, and so I just want to underscore that. And obviously, as I just mentioned, you want to design this care loop where you want to have a human in the loop. And then I oftentimes talk about run this equity game, gate. The issue is there's a go, no go in our checklist. And as I mentioned to you, you want to ensure that you run and simulate the program in a way that says, hey, what are all the conditions that will be needed? How are we going to mitigate any form of setbacks? And if we aren't able to solve those, then we don't deploy it. And that's why I believe we were able to successfully deploy the remote health monitoring solution that we created during the pandemic. And I'll share more with it. So let me just kind of skip forward because I want to show you specifically how we've gone about doing this across, our entire ecosystem. So one of the things that I have done in my work, putting on my leadership hat, as the chair of the Department of Informatics and Health Data Science, it's our newest department. So it's both a blessing and a curse. And one of the things that I was tasked with was to create the department of the future. And what we believe is that our department operates more like a startup and a scale-up because it's highly matrixed. Matrix in the sense that it has 5 key verticals. These verticals really are important where they can stand alone, but they can also cross-pollinate with each other. And so our first vertical is education. The reason why we start with education is because any form of innovation transformation must start with education. Why? Because it makes adoption repeatable. You're training the next generation of clinicians, practitioners, and scientists. And what we say is that we are training the next generation of clinicians, scientists, and practitioners steeped in innovation. And you may ask, so what does that actually mean? Well, we've built a program called the Doctor of the Future, where our goal is really focused on ensuring that we trained clinician innovators, scientist innovators, as well as practitioner innovators. And we call this the Doctor of the Future. It could be the Scientist of the Future as well. It's a pathways program that we provide to our students at the University of Miami Miller School of Medicine. And essentially, here's what we focus on. They, at the end, will be able to lead cross-sector implementation teams. They are able to evaluate tools critically, particularly the digital tools and innovation tools. They'll be able to embed tools into workflows, sometimes scientific workflows and clinical workflows and operational workflows. They design for inclusion. We teach them how to be able to sustain programs. We focus on clinical leadership. We talk about being data-informed care. We focus on implementation skills as well, because there's a completely important dissemination and implementation strategy. We focus on equity by design, and then we focus on collaboration competence. And so what we teach is digital endpoints, we do informatics, implementation science, trust and ethics, equity by design, and communication. But one of the things that I'll kind of go through, kind of quickly, and this is a new idea. I'm actually working on a paper because this is how we've kind of ruled this out. We believe that in order to train the scientist, clinician, and practitioner of the future, that there are three elements, right, that they need. So when we all went to school, not so long ago, that we were always taught that we needed to have critical thinking. But what we see with the proliferation of artificial intelligence, as well as volumes of big data, that what the new skill sets that our students must require or must acquire is what I call information systems management, right? And so information systems management means they have to learn things like ontology, and I believe, Kathy, you spoke about kind of looking at kind of semiology in many ways. Epistemology is critical, as well as logic. And so we created this information systems management competencies where we focus on, our students need to understand what meaning is. They need to have a better sense of what cognitive control in this information age really looks like. They need to understand what these shared definitions are, and uncertainty and quality judgment, and learning how to distinguish between complicated and complex triaging of issues. We also focus on epistemic vigilance and bias resistance, because if you get all these AI prompts, you need to be able to differentiate between that. And then you need to also be able to be a part of a treatment team or any research team where there's transparent triage. The second element outside of information systems management is that we believe that students or any person that's operating in the digital space must have some level of proficiency and literacy around general purpose technologies. They need to have a tool set. And this is important. And so when we talk about general purpose technologies or accelerated purpose technologies, we're talking, kind of AI, artificial intelligence, advanced sensor technology, cloud computing, biotechnology, and nanomaterials and science. And then the third element is what we focus on in terms of this medical innovation operating systems. This is kind of the execution layer, right? So while the information systems management operates in terms of retrieving and getting and finding meaning in the inputs and the like, and then the general purpose technologies are the tools, you're gonna need something that will actually operate the two together. So it's very kind of computer science informed. So sorry if I'm like losing folks here. But this is where, we need to teach folks to have what we call not just a medical, but an innovation operating systems, where it has 6 cores, where you learn how to coordinate resources, set rules and permissions, manage workflows, handles errors, enables updates, and runs at scale. Let me just kind of move through. So when you put these all together, when you have information systems management, when you have the general purpose technology, and you have this new innovation operating system, it allows you to stitch together meaning, capability, and execution. Because the information systems management framework is the meaning layer, the general purpose technology is a capability layer, and the innovation operating system is an execution layer. A lot of us in the engineering and computer science space are now talking that we all need to create second brains, digital brains of how we operate. I'm not going as that far, but I'm laying the case that because of this, kind of proliferation of information, this is what I think we will need. One of the things that we try to do is that we leave our students with what we call an innovator toolkit, so they know how to have this workflow map template and know how to do kind of burden budget checklist and a trust script. And as I said earlier, the equity gate walkthrough and the dashboard. Let me talk about the other vertical in terms of research. We're very bullish about creating this new framework called precision and personalized population health. Excuse me. And the goal with that is that we want to be able to discover. We believe that translation of any type of idea must lead from discovery all the way to treatments and solutions. And discovery comes first. We need to be able to identify new etiologies of disease, but also understand why certain treatments work for whom. But then it's important to also establish treatments and solutions and to translate those into awareness. Can we use digital solutions to make people more aware of their risk? Can we use digital solutions to actually push forward avoidance, or what we call prevention, so that if you know that you have some form of risk for a particular chronic health condition, can you use digital solutions or innovations to be able to help you to prevent or to avoid that particular condition? And then digital solutions and innovations can help to improve access. It can help to improve assessment, acceptance of treatments, as well as adherence. And so I'll just kind of walk you through how we've gone about establishing a digital health equity and inclusion model where we're focused on barriers and digital solutions and outcomes. And we look at a wide variety of different factors from intrapersonal to interpersonal, as well as how is it that we can scale that. And we've done this in sleep health, and I'm more than happy to share the paper. Don't think we have a ton of time to do that. I'm happy to share more in detail. But when you actually have this really nice framework where you're solving for challenges, solving for opportunities and an ethic, then it allows you to build these more durable types of frameworks like what we did for the sleep health community. But it also helps you to be able to focus on real world data. We actually at the University of Miami created the Harmony Alliance, which stands for Healthy Aging Research to Improve Medical Outcomes Needs Through Innovation. And this was actually a solicitation by the NIA to create a real-world data platform. So think of it creating the NHS, because we don't have that system at all, but doing it retrospectively using technologies. And so, unfortunately, no one got that grant, but we're actually incrementally building this. Yes, we teamed up with Palantir, whatever your thoughts are about Palantir, but we've teamed up with them to be able to stitch those data together, as well as some really large big data companies as well. This has also allowed us to revolutionize how we actually roll out research. We know that our clinical trials are not as representative as we'd like them to be. And our thesis is that we can use decentralized trials to actually improve inclusion. And so we actually wrote a paper, was published, I believe, earlier in 2025 in Science, where we laid out our Maverick idea, the You Decide program, where we showed how our new approach of decentralizing research at all stages, at the recruitment stage, at the screening stage, at the informed consent stage, at the randomization, to intervention and monitoring, and even incentive, has really kind of driven our success and uptake of being very inclusive. It's been said that the average driving time to a clinical trial site is about 2 hours, right? Let me say that again. The average driving time to a clinical trial site, and I think it's obviously FDA clinical trial site, but nonetheless, that it is very burdensome to get people to come to sites. And if you have a site-specific clinical trial or study, you are actually selecting out people who could benefit, and you are selecting out the representation. And so what we have done, I think, really nicely in Miami is to be able to be more inclusive by decentralizing it. And how we have done that is the creation of the mailbox. I can now say the award-winning mailbox because we won award from T-Mobile and Malcolm Gladwell for the Tipping Point Award. Because what we've done is that we've created our own remote health monitoring solution, and I kid you not. The creation of this, I mean, I don't mean to pick on me. I know that I'm follically challenged, but it really accelerated during this period. We were very blessed at the beginning of the pandemic to get 3 R01s. And how we would normally do business, we'd have a tech going to people's homes and the like. And I remember our tech would go to set up the home-based sleep tests. And he went to an old, wonderful lady. I love everyone, but I don't know if you know and I don't mean to be stereotypical, but an old black church lady in Brooklyn. And she was like, honey, you ain't coming in here, man, because I don't want to get that Rona. And we were like, and then it was her, and then others came, and we were like, how are we going to do this? And remember what I told you. You solve when life presents challenges, and you solve when life presents opportunities, and you solve when you have this obligation and responsibility. And this is really the amalgamation of all of those 3 things. So we said, you know what, we're not going to sit put. I had this wacky idea a long time ago of creating a remote health monitoring solution, and we created it. And through the phenomenal partnership with telecommunication companies like T-Mobile, we were able to provide an iPhone to everyone in the study for the duration of the study. Of course, we paid at a nominal fee, but what we said was we did not want to burden anyone. We did not want to exclude someone because they did not have a phone. And now we are able to collect digital biomarkers in real time. This has allowed us to really advance our big vision of creating digital twins of everyone. And the digital twin will allow us to really capture both the biometric algorithms as well as the biological algorithm of individuals, which I believe is the precursor and the foundational model for precision medicine. And it will become the new electronic medical record of the future, where we're no longer providing care that is based on trial and error, but is going to be steeped in real engineering and science. And so here is it, that yes, there is importance of ensuring that your work solves a challenge and sees an opportunity and ethic, but because of how grounded our research program was, we are now able to pursue things that is phenomenal. We're creating a program called the Million Faces Project as well, where we are focused on skin lesions. And one of the things that we know is that many of the large language models don't have good representation of people on the 5-6 Fitzpatrick scale. And what we do know is that when African Americans or people of African ancestry get some kind of skin cancer, that they're oftentimes delayed and it's too advanced because the models just don't really do a good and accurate job. So we're trying to be able to build that, and we're trying to do this in trying to tackle Alzheimer's disease as well. We're doing this in research for advanced computational and digital biology, where we're actually using not just digital twins, but also finding AI kind of AI to be able to build new drug therapies. And my big vision is that we're working with companies to create what we call the omniverse of research labs. So where if you're a wet lab person, you also have a digital lab as well. And the information that you get in the wet lab as well as your computational digital lab are actually feeding each other, because it takes about 17 years to advance any particular intervention, from a drug all the way to getting out to the community. And we believe that we can use AI and technology to be able to do that. But we also must ensure that what the research lab looks like of the future is not just kind of confined and restricted to how we do business as usual, but we can use new technologies to be able to do that. And so this is why we're very bullish about that, about our vision for digital twins. We're working on that. We have submitted a paper that's currently under review where we've laid out the engineering as to how to be able to do that. I didn't want to go too deep in that as well because the paper is under review. But I'm happy to talk to people, offline. I'll just skip, briefly because I think, I think Kathy already mentioned a lot in terms of setting up kind of secure environments and data architecture. I'll just briefly go through clinical. Why is it important to have, clinical is our third vertical. And one of the things that we focus on is that we want to ensure that we create a frictionless, decentralized, and democratized healthcare system where it serves all. And the critical thing for that is that we've used digital therapeutics to do this. And I know that's something that Metrics is focused in as well, even though their primary focus has been really tools and collection of data. But digital therapeutics, I think, helps to provide standard quality care. And how we've gone about doing that is that we created a femtech program. I think we're one of the first academic femtech programs in the world. And we're very, very, kind of proud. We're very proud of that. You're happy to join our Femtech Fridays, where we feature, women's health technology programs. We led a small pilot project where we provided virtual reality solutions to 50 Black and brown moms to provide education on kind of the whole perinatal care, provides education around pregnancy, but also providing mental health and meditational services while pregnant and after, because postpartum depression and postpartum distress, they are real things. And what we found is that particularly among Black and brown communities, that it goes underreported and there aren't enough care. In Florida, about 68% of individuals do not live close to a licensed mental health practitioner. So we have a huge shortage issue in Florida. And this is where digital solutions can fill that gap in providing quality care as well. And so in our venture vertical, we focus on what we call research, development, and dissemination. I believe that this is really a game changer. My big view is that academic institutions need to reclaim their rightful right of being engines of innovation. That yes, it's important to have private industry lead innovation, but we actually need to be leading not just the intellectual property, but the innovation with and for a purpose. That is critical, and we've gone about doing this. Several programs, we've created a white glove industry engagement program where we work with different companies. We want the University of Miami to be one of the most hospitable schools for companies to do first in human studies, pilot studies, and validation studies. We're very bullish about partnerships as well. We support many different startups by providing consultancy, and we believe in entrepreneurship fellowship. Not just entrepreneurship fellowships for big tech, but the University of Miami is historically situated in one of the first African-American communities in Florida, and unfortunately, through gentrification, that it has been completely eviscerated. Any of you guys know I-95, when they put I-95 that runs all the way south from the Keys all the way up to, I don't know, where Maine or wherever it goes, that it cut through the community called Overtown. And so on one side, it's Overtown, and then the other side is all the great place that you all like to go and visit, like Brickland, downtown Miami, and the like. And I want y'all to come visit Miami, I'm not saying that, but it has completely eviscerated us. And so the entrepreneurship that we provide, and this came up when, my colleague and I were walking through the community, and, I was kind of looking like this. I had a suit on, and they knew that I was out of place. And so, I tried to walk with a little swag and stuff like that to see that I fit in. And the kids would look at me and wonder who is this dude? And then it made me realize that because we're a school of medicine, that the community looks at us as more, that we're not just there to provide care, that they see us as a beacon of hope. And so we need to provide services whereby young moms, young dads, grandmas, grandpas can build new programs and entrepreneurship opportunities. And that's what we're very bullish about. And we have done this in apprenticeship programs as well as incubator programs as well. And we've created a de-risk tool. So I know many of you, I'm happy to talk to you, after we've developed a de-risk tool, because I'm sure you are bombarded with so many different tech companies and you're like, we have the best depression intervention and we want you to pilot it. And then in 2 days, another one comes. And then another one, and then another one. I sound like DJ Khaled, for those of you who don't know the reference or anything like that. A little bit of a Miami reference. But that's how it is. And we felt that you needed to actually create a de-risking tool that we've laid out, and we're happy to share with you in terms of how you can vet folks so that you're not inundated with so many of these requests. And then our last vertical, is very near and dear. It's service outreach policy and ethics. This program is near and dear to me because we are really trying to tackle issues around digital literacy and the digital divide. We just published a paper where we focused on the issue around the digital divide is not about access. It's really about affordability, adequacy, and the like. And when you have a world that is so polycentric, meaning when you have an issue and a dilemma of the digital divide being so polycentric that you need policies that reflect that asymmetry as well. And so we laid out a rhizomatic policy approach that in terms of how we can do that, and we're trying to really solve that. And we're doing it not alone. We're doing it with, some of the biggest tech giants as well. And so I have really interesting, fond feelings about them. It's how you engage them, to be quite honest. They're not the scary big bad wolves. And so we're also focused on diversifying STEM initiatives. We go to the community, to high schools, because we believe that we need to train the next pipeline and generation of technologists. And that doesn't mean that your research has to adopt this, but it could be a student, right? That you have to be able to train the next generation steeped in this as well. And the reason why this is important is because, I believe that, innovation is critical, because it's my belief that the way in which we are going with all these new technologies, that on one side, you can capture as many data as possible, wrap around 360 degrees of the human being, but you also can, and we're focused on this, we're talking to some companies right now, to be able to create smart homes for individuals, particularly for the elderly, where we're tethering these together. And then we're working with our fantastic municipal leadership as well to make it smart cities as well. This is important because as human and technology are becoming more ambient, AI is becoming more human. And I really believe that many people may say that AI is actually ridding us of our humanity. And yes, that is a huge concern, but I believe that it can make us human again, and it can make research more human again. And the reason why this is important, I believe, is because having an innovation framework that tackles challenges, seizes opportunities, and operates on this enduring guiding ethic of innovation with and for a purpose really makes healthcare and our research fulfill its true role. It allows what we do to be more wise. We are enamored by intelligence, and that's just kind of how the Western world works, and nothing is wrong with that. I believe the greatest virtue and the greatest level of insight is wisdom. And we can do that through data and analytics and smart systems. But it allows our work to be more compassionate. And as I'm looking out at the young folks here, because I think you will be compelled to be the smartest one in the room. And that's okay. But the greatest virtue is that you are someone who is wise, but also compassionate. Is your work in service of others? Is your work caring for the total well-being of human beings? But that must be anchored in humility. Not just you as an individual, but as a system, where our systems become learning systems because we just don't know it all. We're constantly learning and updating, and it keeps us accountable. But more importantly, it makes what we do just. I was sharing with a colleague yesterday that justice is love expressed outwardly. That you can tell me that you love human beings, but you don't show me through justice, then it means nothing. It's just words. And so the work that you do, I encourage you to ensure that it is fair, transparent, and inclusive. Thank you all so much.
All right, we have about 5 minutes for questions, and we will, if you raise your hand, we'll find you with the mic.
I'm glad I didn't put them to sleep, Kathy.
No.
And when you speak, do you mind just saying your name? Because we're going to be together, for an entire day, and I'd love
Absolutely.
to. Yeah, please. Thank you.
My name is Gabby. I'm with the Proctor Lab here. Thank you so much for your talk. It was great. From a social worker perspective, I was kind of thinking of like program evaluation and how you guys guide that over time and kind of measure objectives. So my interest was after the success of kind of numerous projects, were conversations kind of revisited with community members, with stakeholders to see if those affect-based objectives were achieved. So did you see changes in values? Did you see changes in kind of beliefs and thoughts around these technologies overall? Because like you said, you go into communities and a lot of people have notably invalid, guarded perceptions of people coming in, even though they look at a medical professional or the medical community as a pillar. So I just wanted to know your thoughts on that.
Well, Gabby, pleasure meeting you, and thanks for doing your very courageous work. We have seen, and we have a community steering committee of 15 individuals, and they serve as ambassadors in the community. And when we engage with the community, at first they're a little apprehensive. There are times, particularly when we distributed the mailbox, and I remember this one old Hispanic lady. She called us. She opened. I don't know if this is exactly what happened, but this is kind of me, and I'm not trying to laugh at her. But she opened it and she closed it and she's like, "Come get your box. This is too much for me." And so you will have those individuals, and we're actually trying to study scientifically, for whom the technology might be more appropriate for. And what we believe, and we actually wrote a paper called the pan-theoretical approach, where we knew that was going to be the case. But let's say, for example, if you have a patient who, just for their own health may require and need some form of tracking or digital intervention, you're going to have to scale them up. And that's what our digital literacy program really allows to do. So I want to bucket that there are profiles and phenotypes of individuals for whom it just will not work. And that's totally fine. Now, in terms of the people who have adopted and where we've seen significant uptick, it really has changed attitude in the community. We have a whole lot more folks wanting to be a part of it and actually asking the local federally qualified health centers to have programs. So just last week, we had a nursing home reach out to us who said, "No, we're being asked because they hear about a lot of your aging research and the like, that we want to implement some form, of smart and connected home technology." And I think we have seen that change. We're very, straightforward with them about the transparency of it. One of the things that we have done, our best to do is to make sure that we protect the rights and the privacy of our participants as well. And then another thing that we also do, which, I think everyone would be in full agreement. When we distribute the mailbox, the remote health monitoring solution, we provide a summary of what their readings were. And we have a study physician, and they will call the study physician and they will speak to the study physician if they have any questions or concern. That's how we layer and operationalize trust. It's not just a binary like, yes, I trust it, no. It's, well, I'm going to see exactly what this product or solution does. You showed me that there was a product at the end of it by providing a summary of their scores during that week. And oh, by the way, there's accountability. The same frameworks that I laid out, earlier. There's an accountability, a study physician where they can speak to. And many of those individuals don't have a primary care provider. And so that study physician, not that it should be a substitute, but our remote health monitoring solution ends up being a physical in the box for many of these individuals. And that's where we feel as if we have built more trust. I don't see trust as kind of a black or white categorical thing. It's really something that we have to continue to earn in the community. And that's what we're trying. We're very transparent. We provide lots of education as to what we collect, who we give their data to, and the like. And we honor them, as well. We provide newsletters to give them updates. They feel like, they are the stars of the show. If there is, a press release that's being done on us, the journalist will ask if there's someone. Obviously, we speak to the IRB, but when we go to those individuals, you're like, oh my goodness, like, thank you, yes. And they become the protagonists of those studies, not us. And that's another way of earning more trust. Thanks for your question.
Hi, Dr. Azizi. Thank you for coming and being a winter Wolverine with us today.
Yes, I love it.
I really enjoyed your presentation
You're
and
very
all
kind.
of the pipelines that you have built with your team, your governance, not your advisory board. That really stuck with me. And I want to really learn on how has your governance become more bonded with all your 5 verticals, your D6As. These are all great implementations, but I'm thinking as a study coordinator, there's a lot of things I put myself and I look at my team for guidance. So how are you kind of displaying your guidance to your team?
No, excellent. No, that's an excellent question. In as much as my slides were quite voluminous, it doesn't capture everything. And maybe it's just me just trying to be a big thinker, but it's very intense. And so I can appreciate coordinators kind of serving as that bridge between, kind of research associates and staff members on the ground, and that bridge to the PI or other leaders. You are smack right in it. In terms of how we've tried to implement it, I try to be as best as possible to be present and to educate. I invest a lot in our coordinators and on our team. We're very transparent about it. We have, some dashboard element to it, but there's always, training, around, how to be able to do that. In terms of what we would love to do, can we set up some kind of agentic ecosystem to make it less burdensome? We're talking about it, but I think a lot of what we do is more frameworked. So it's not like it's kind of a deterministic sequence of contiguous steps per se. It's more so this is how we need to be able to build out, these programs. So for example, when people join our team, they have to read kind of the Bible, so to speak, in terms of how we roll out these programs. And we constantly talk and communicate and we work, on this. But it's very, very multi-layered, to be quite. But I'm happy to chat more, offline to get into the details of it. Thanks.